legitimately be described as having 3-drug hypertension. But you can see that the patient on the right is taking double the dose. And in the same way that we are trying to standardize outcomes from surgery by means of the PASO score, people are trying to standardize the tablet burden. And you'll increasingly come across this thing called the defined daily dose. It's quite useful for comparing series across the literature. So let's go back to our PASO online calculator. We're trying to introduce something that the patient can get his or her head around when we're discussing whether they want to go forward for something that's invasive, adrenal vein sampling, and something that's even more invasive, abdominal surgery. So let's give this patient 5 years of hypertension, that's 60 months. Let's make her female. Let's make her slim. Let's give her a defined daily dose of 6. She has no target organ damage, and she has a reasonable size nodule in one of her adrenal glands. Using the PASO online calculator, we can look her in the eye and say, I think there's a very good chance that you will completely come off all of your tablets after an adrenalectomy. Let's think of another patient. This patient's had hypertension for 10 years. He's male. He's overweight. Same defined daily dose of drugs. This patient's got some left ventricular hypertrophy, and this patient's got the same size nodule. So much is the same, apart from the gender and the duration, and he's not as slim as the other patient. You can look this patient in the eye and say, I have to say it's very unlikely that you're going to come off all of your tablets. Now, the PASO online calculator is not flawless. It's a prediction, not a promise. And it gives you the outcome for the average patient of 100 patients that look the same as one another. But in terms of trying to introduce something and get away from all of those, yes, but we might not, yes, but we may, or yes, but we might not, it can be quite helpful in allowing a patient to get into the consultation. What can you offer me, doctor, before I subject myself to something called adrenal vein sampling and surgery? Now, PASO is not flawless, and the terminology is not flawless. And let's imagine a scenario in which you had a patient who was taking 6 pills for their hypertension. They have an adrenalectomy, and at the end of that, they're down to 1 pill. I think the Oxford English Dictionary would describe that as a success. Maybe you would describe it, and the patient would describe it as a triumph. The PASO English Dictionary describes that as a partial success, because the patient is still taking a tablet after the surgery. So you just need to be a little bit careful between the Oxford English Dictionary speak and PASO speak when you're talking to patients. And just be careful when you talk to them about partial success. That's a terminological tool that we use to compare studies between centers and across the literature. And just be careful that if you say to a patient, I think I'm going to send you to an operation, and I think the operation is going to be a partial success, I think the patient might have something to say about that. So this is a research tool. It's a way of comparing results across centers. Just be a little bit careful with the language when you translate that into a consultation. So there are things that we can do to avoid adrenal vein sampling because we know the answer already. And one of the ways is to use anatomy and age to predict that somebody is highly likely to have unilateral disease. And the standard teaching is that if you have a focal, clearly identified adrenal nodule, and the contralateral gland is normal, and the patient is young, and they have what in the document is described as marked primary-hyperaldosteronism, the definition of which is a little bit woolly, then you can avoid adrenal vein sampling because you know that in this patient, the problem is in the right adrenal gland where there's a lump. And if you look at that slide, it looks totally straightforward, doesn't it? Age, unilateral abnormality, contralateral normal, and marked primary-hyperaldosteronism. But life is never quite that straightforward. So I'm showing you a few examples here, some sort of package deals, just to give you a flavor as to how you might approach this. So this shows the CT scan that I've just demonstrated to you, a neat focal nodule in the right adrenal, a perfectly normal left adrenal gland, classical Conns with hypokalemia. The patient's 37, so technically they're a year or two older than what the guidelines said, but I personally would be fine about sending this patient to surgery without adrenal vein sampling. And the point that I'm going to show you in the next 2 or 3 scans is that you must associate yourself and find yourself a cross-sectional radiologist who is going to love the adrenal and obsess about it and report it meticulously. I'm sure you work with some terrific radiologists who report cancer and liver disease and bowel disease. There are very few people who can really, really get into the detailed anatomy of the adrenal. And my strong suggestion is that you find a colleague who's going to work with you and travel with you on your learning about primary aldosteronism, because you cannot do this without a top-class cross-sectional radiologist who is going to be really interested in and obsess about the adrenal morphology. So let's have a look at another one. 32 years old, the age is fine, the biochemistry is perfect, classical Conns. There's a lump in the right adrenal gland, but that left adrenal gland just looks a little bit too knobbly for my tastes, and I cannot declare that to be completely normal. So I have to send that patient for adrenal vein sampling. This patient, a neat nodule again in the right adrenal gland, but those limbs on the left just look a little bit thickened. And it would only be a really experienced adrenal radiologist who's prepared to have feedback case after case after case as to whether you as a team got it right or wrong, who would start to call that out and say, I don't think the left's quite normal. So this patient has to go to adrenal vein sampling as well. This patient's got a nice nodule in the left, the right's unequivocally normal, nice and young, but we've needed a saline test to diagnose the primary aldosteronism. It's definitely there, but I don't think you can describe this as being marked primary aldosteronism, as suggested by the Endocrine Society document. So lots of different combinations, and the key message is to find a radiologist that you work with regularly and to work with somebody who is prepared to have gentle, constructive feedback as to what the outcome was. Not implying criticism that he or she got it wrong, but be prepared to learn with you over 5, 10, 15 years and get really, really good at CT scan reporting. The next way we can potentially cut down on adrenal vein sampling is because we know the answer is going to be bilateral. And there are lots of different prediction models. I'm showing you 4 here on an ROC plot, which a colleague of mine, Sam O'Toole, my old research fellow, did, and which he submitted for publication. He's compared our data with these 4 scores. You don't have to remember all of the detailed scoring system. I'll summarize it for you in an easy to remember clinical lesson, which is that if you're normokalemic and you have unequivocally normal adrenal glands morphologically, it is highly unlikely that you're going to lateralize, and it's highly unlikely that you're going to get yourself into trouble by not offering that patient adrenal vein sampling. But the key to that green box is normal adrenals, and it's another example of which you really need to get close to a colleague who's going to be prepared to say, I think they're unequivocally normal, and that is surprisingly difficult to do. So far, we've covered a few things in trying to match our supply and demand. We've had a shift of mindset. Surgery is not the first prize. It's an option. We've got our spectrum of severity, and we're going to send our 32-year-old young female who wants a pregnancy definitely to surgery. And we're probably not going to send our multi-morbid patient who's overweight, who's had a stent, and who's only on true drugs. We're probably not going to send that patient for surgery. And between, we're going to think about it very carefully. We're going to use potentially our PASO online calculator, not as a promise, but to just help the patient get his or her head around what the odds are. We're going to make use of focal nodularity with normal contralateral morphology in young patients. And we're going to make use of this very useful rule that if you've never been hypokalemic and your adrenal glands look like yours and mine and are normal, it is highly, highly unlikely that you will lateralize. So that patient probably doesn't need a test. So we've still probably got too many patients for the capacity for adrenal vein sampling. And for those people who are not endocrinologist, you might say, what is the fuss about adrenal vein sampling? Why is it so restricted? And why are you making such a big deal about it? Well, the answer is the right adrenal vein, which needs cannulating, is 2 millimeters long and 1 millimeter wide. And it comes off the inferior vena cava at an acute angle. So it is a radiological masterpiece of work to get into that adrenal vein, accessing it from the femoral vein. It's a really, really difficult thing to do. And in the United Kingdom, where I work, there are probably only 6 or 8 people who can do it to a very high standard and get up to that 85, 90% bilateral cannulation rate. On the left, it's much more technically easy because you go via the left adrenal vein, but it's the direct association with the right adrenal vein and the inferior vena cava, 2 millimeters long, 1 millimeter wide, that makes this so technically difficult, which is why we're constantly looking for alternatives to that scarcely available test. And the question I'm posing here is, can we avoid adrenal vein sampling in somebody who, in our heart of hearts, we really think the problem is in the right adrenal gland? She's 43, she's female, she's got hypokalemic hypertension, she's got classical Conn syndrome, she's got a very attractive nodule in the right adrenal gland. But the annoying thing is, she's had a few birthdays too many to offer her surgery without a lateralization test. She's not 35, 36, 37. I'd be okay with that. Aged 43, there is a 3 or 4 or 5% chance that that nodule is a completely incidental, clinically functionless lesion in the right adrenal. Really, the chances are that it probably is the source of the problem. Is there something that we can use just to get us over that certainty line and go for surgery without AVS? And the answer to that question is maybe. The architect of what we're talking about today was Jerome Conn, and if he were to be a time traveler and arrive in your clinic tomorrow, he would get a surprise when you presented the pathology of somebody who underwent an adrenalectomy for Conn syndrome. Because your pathologist would say, you're telling me that this patient is producing too much aldosterone, and aldosterone is made in the outermost layer of the adrenal, the zona glomerulosa. But I'm telling you, Jerome, that this tumor looks as though it's come from the zona fasciculata. It looks like they are cortisol secreting cells. And Jerome Conn, I'm sure, would not believe him or her. Now, what's all this about? This is the sort of thing that we remove when we remove a Conn's adenoma. And the most common mutation that we find, particularly in Caucasians, is a mutation of an inwardly rectifying potassium channel called KCNJ5. Now, if you're a cholesterol molecule and you want to become an aldosterone molecule, you have a long journey ahead of you. And 2/3 of the way along the journey, you need an enzyme called 18-hydroxylase, which converts corticosterone into 18-hydroxycorticosterone. If you're a cholesterol molecule and you want to become a cortisol molecule, you have to take a different route. Now, the important thing about these KCNJ5 mutated adrenal adenomas is they express the enzymatic machinery to make both cortisol and aldosterone. So normally, those two layers just express the enzymes that you need to make the hormone that you're interested in. But these hybrid cells make both sets of enzymes. And the result of that is that cortisol can continue its metabolic journey into a compound that you and I don't really make in health, which is called 18-hydroxycortisol. And this is what we call a hybrid steroid because it requires the enzymatic machinery from 2 different layers of the adrenal gland. We can measure it. And my thanks to my colleagues in Birmingham who measured it in our match study, which I'll show you in a second, which was published last year. We're looking at the ratio of this hybrid steroid, 18-hydroxycortisol, to cortisol in urine. And what you can see is that those people who carry the KCNJ5 mutation have an elevated level of the hybrid steroid compared to all of the other mutations that we've documented in the study, with just one exception. There's clear blue water between the vast majority of all of the other mutations and the KCNJ5. So let's go back to our patient. She's 43, she's hypertensive, she's hypokalemic, classical Conn's, and there's a lump in the right adrenal gland, but dash it, she's 43 years old. What if we were to measure the hybrid steroid in her and be confident that not only is that the source of the problem on the right, but it's almost certainly a KCNJ5 mutation. And the bit of information that is the tantalizing thing is that if you have a KCNJ5 mutation, it is highly likely that you will be completely cured and come off all your tablets. So this is a potential thing to incorporate into clinical practice for two reasons. First, it might avoid in this type of patient an expensive, invasive, and not very available investigation called adrenal vein sampling, but it could also inform the consultation with your patient in whereby you could say, I really think there's a very good chance that you will stop all your tablets altogether. But still, I think we've got a problem because there aren't enough interventional radiologists to do this test. And I'm going to talk to you for the next 2 or 3 minutes about molecular imaging. I'm learning fast about molecular imaging and have been involved in a study for the last 8, 9, or 10 years. I'm getting to know quite a bit about it. But really, the trailblazers in the United Kingdom were 3 colleagues of mine, Morris, HK, and Mark. And I would particularly highlight HK Chow, who's a brilliant radiologist, softly spoken, very scholarly, and he has the most experience in the world of reading these molecular images of the adrenal. Now, the principles are that if you have an aldosterone secreting adrenal lesion, I'm showing it to you here in the arrow just underneath the liver there, there's a lot of this going on. Cholesterol all the way down to aldosterone, and you will need a lot of aldosterone synthase to do that, and that enzyme will be very active. That high aldosterone level will suppress the renin, and so the activity on the other side of the adrenal will be very low. There'll be very little aldosterone synthase activity in the contralateral adrenal. And you're familiar with this principle in your endocrine practice because you do a lot of technetium scans or iodine scans, I'm sure, to look at toxic nodules. So here I'm showing you an active lesion in the right hemithyroid, suppressing the left hemithyroid. The same principle applies for molecular imaging of the adrenal. The question is, what's the ligand that we're using for the adrenal? What's the technetium equivalent in the adrenal to the thyroid? And at the moment, there's most experience with an old veterinary anesthetic agent called metomidate. And metomidate binds to the enzymes that synthesize aldosterone and cortisol. So it's non-specific. It will bind to aldosterone synthase and cortisol synthase, which we call CYP11B2 and CYP11B1 respectively. But if we give the patient dexamethasone and we turn off cortisol production, we can convert metomidate into a selective aldosterone synthase ligand because we've taken away the enzymatic activity of the cortisol synthase. And this is the sort of thing we can get. On the left-hand side, you can see a right adrenal nodule. You can see the PET scan and the overlay. And this is the sort of investigation that we've been looking at and comparing with adrenal vein sampling. And in a large number of patients, 142, who had both adrenal vein sampling and metomidate scanning, we've compared their accuracy in predicting the outcome from surgery. This is the study. We confirmed primary aldosteronism, and all patients had both scans in random order. The metomidate PET-CT scan was scored and graded high, low, or medium probability of unilateral primary aldosteronism before the adrenal vein sampling result was revealed and analyzed. So that was scored in ignorance of the AVS. The patients then started spironolactone or eplerenone if they could not tolerate spironolactone. We reviewed all the data, and if you had one of those investigations that suggested a high probability of unilateral disease, you proceeded to surgery, and you were followed up at 1, 3, 6, 12, and 24 months. If you did not have evidence on either test of lateralization, you were managed medically. And I'm showing you the results here. I mustn't go into Paolo's time, but I think I'm all right. And what I'm showing you here is that the most common scenario in the yellow was that both investigations concurred and predicted the outcome from surgery. But you can see in the green that metomidate is performing at least as well as the criterion standard adrenal vein sampling in the blue. And if we look at a forest plot, we can see that on declared non-inferiority margin of minus 17.5% is cleared, and we can therefore declare that molecular imaging using metomidate is as good, as accurate, non-inferior to the standard invasive adrenal vein sampling. That's the headline from the study. And at this point, I should acknowledge the fantastic research staff, the junior faculty that delivered this study through the pandemic of 2020 and 2021. They were absolutely outstanding, and without them, nothing would have happened. The problem is that carbon-11 metomidate has a short half-life of only 20 minutes, so you have to synthesize it on site using a cyclotron. You could not synthesize it at one center and ship it to another center. The other problem is that the dexamethasone converts metomidate into a selective ligand for aldosterone synthase. But the problem is some nodules co-secrete cortisol. And so in those patients, the metomidate will bind potentially to some lingering activity of cortisol synthase. So a trap to be avoided with metomidate is the false positive of a nodule that's actually secreting cortisol rather than aldosterone. The second issue, or the major issue with metomidate, is the half-life. And so we have compared a sister ligand, ceto, using 18-fluoro, and compared it with carbon-11 metomidate. And here I'm showing you an example of a metomidate on the left and a ceto on the right in unilateral disease. And I'm showing you an example of bilateral disease, metomidate on the left and ceto on the right. Now, the attraction here is that the half-life of 18-fluoro is about 2 hours, and this opens up the possibility of using ceto in any center that is conventionally using 18-fluoro FDG, for example, which I'm sure is very common in the centers that you work at for cancer imaging. So it may be that here we've got a ligand that can be distributed to different centers and is therefore not confined to the center that does the synthesis. More work to be done with ceto, but we've got preliminary results that we're just analyzing and submitting for publication. Now, the final thing that I'm going to show you is not so much about lateralization, but about the extra information that molecular imaging can give you. Adrenal vein sampling lateralizes the problem. It tells the surgeon to take out the right adrenal gland or the left adrenal gland. But molecular imaging lateralizes and localizes, and that's potentially of interest if we want to treat just the nodule as opposed to removing the whole adrenal gland. And what I'm showing you here is an endoscopic ultrasound scan, and on the end of that endoscopic ultrasound device is a needle, which is going to go through the stomach wall into the left adrenal adenoma that I'm showing you on the ultrasound image. And here's a patient who's enrolled in our study, our pilot study of endoscopic ultrasound transgastric radiofrequency ablation of just the nodule guided by the molecular imaging. So here's the patient, 4-drug hypertension. There's the left adrenal aldosterone secreting nodule seen on the pre-ablation scan. He has that procedure that I showed you on the previous scan, an endoscopic ultrasound scan, identification of the nodule, through the stomach wall with the needle, radiofrequency ablation. It takes 10 minutes. And here's the post-ablation scan. The lump has gone, and he has normal blood pressure without medication. So we're now doing a randomized study of total adrenalectomy versus transgastric endoscopic ultrasound-guided radiofrequency ablation. We're about halfway through recruitment, and we'll tell you the results in a year or so. There are other ligands other than metomidate and ceto. One is CXCR4, which is a chemokine ligand. And there is a new aldosterone synthase ligand, which is specific to aldosterone synthase, does not bind the cortisol synthase, so it does not need the dexamethasone, and is therefore potentially attractive because it probably doesn't identify false positives. This scan has only been performed in about 12 or 14 patients. I've put some patients into that study, and I'm a collaborator in that, but that's very early days for that particular ligand. But I think you might hear more of that in due course. So if you wanted me to give you a soundbite, it's not so much that I want to ration the use of AVS, but I think we need to make the use of AVS more rational, and I hope I've given you an insight into how we can do that. It all requires multi-center, collaborative investigation and clinical trials, and I would very much welcome the opportunity to discuss the design of those trials, get the opinion of Professor Mulatero on what we've done so far, and I will answer any questions that you have